Trust me. Thank you, ma'am. May I call Dr. Prasad, sir. Sir is DNB sir is doing DNB cardiology in Department of Cardiology, Triple SIHMS Whitefield. Sir will have a talk on TMT.
As Prasad starts, I'll tell one thing. Prasad, he can take over. You should know every single word of TMT. Okay. You cannot go for the exam without knowing TMT protocols. He may not be able to finish it. He's done a great job. I saw his slides, but it's your bread and butter. They expect everything as a long question, short question, individual things, the output, that is types of ST depressions, this, that, everything is asked in TMT as a 10 marker, 5 marker, 2 marker. So I'm sure he'll do justice. But as it said, it's not just under run of the mill. TMT is very, very important in CCT exams. Sorry, Prasad, go ahead.
Good afternoon, everyone. So we'll go through the talk soon. Okay. And introduction, it's run that teaches you a lot. It's just a 10-minute, 15 minutes procedure, but it teaches you a lot. And it's not just a test. It's a guide to plan the management and to prognosticate. So history was initially the treadmill was used to punish the prisoners in England. Later, the modifications were done, and in 1952, Robert Bruce is the father of exercise cardiology. He invented the first motor TMT. So, what is a physiology? Whenever there is a dynamic exercise going on in the body, there will be increased energy demands, increased energy demand of the muscles, and there will be increased cardiac output as a result of increased heart rate and increased stroke volume. And myocardial oxygen demand will increase, and there will be resulting increasing coronary blood flow in the coronaries. So normally there will be a dilatation of the coronary arteries, and the coronary blood flow rises as a response to the exercise. But in a stenosed vessel, because of endothelial dysfunction, neuromodulation, and local factors, there will be a compromise to the supply of myocardium, and sometimes and atherosclerotic arteries fail to dilate, and actually there will be constriction of coronary arteries when there will be when there is an exercise going on. So what are the factors that influence the significance of given luminal stenosis?
Go to TMT straight.
Yes, yes.
Go to TMT straight.
So we'll go through the procedure per se. So patient assessment, we have to assess the diagnosis for which TMT was asked, symptoms of the patient, risk factors that were present, and recent illness like any recent MI or NSTEM in the patient, drug histories, whether the patient is on beta blockers or digoxin, because they will have an effect on your TMT result, and functional capacity, and you have to examine the patient for resting pulse rate, BP, and auscultation of lungs, whether the patient is in heart failure or not. And preparation, patient should not eat for 3 hours before the test, and routine medicines may be taken with a small amount of water, and you should explain detailedly, and sometimes you may need to demonstrate them initial phases of TMT. And TMT, it is a test which makes physiological stress like walking to attain higher oxygen uptake and peak heart rate. And the lead system, standard 12 lead ECG with electrodes placed on the limbs cannot be obtained during the exercise. So the limbs ECG leads are placed on the torso of the patient, and the torso electrodes are placed in the lateral aspect of the clavicles for the arm leads, and rib cage for the leg leads. This is called as a Mason-Liker modification, and the lateral limb leads were placed on the lateral side of the clavicles, and the dorsal leads can be placed at the lower end of the rib cage or at the anterior superior iliac spine. And Mason-Liker modification will cause there will be a right axis deviation and increased voltage in the inferior leads, and loss of Q in inferior lead, and new development of Q in AVL. So these are the modification changes of ECGs. And there are multiple protocols. There is modified Bruce protocol that's commonly used, modified Bruce, Cornell's protocol, Norton's protocol, and we generally use Bruce protocol. It's just formulated by Robert Bruce, and it is published in 1963. And it is a multi-stage treadmill for assessing health. And every 3 minutes, there will be increase in speed and incline of the treadmill. And there are 7 such stages, and each stage there will be increase in 2% of inclination. And the modified Bruce protocol starts at lower workload and typically used for elderly and sedentary patients. The first two stages will be performed at 1.7 miles per hour at 0 degrees and 5 degrees grade. And the third stage of modified Bruce corresponds to stage 1 of Bruce. And patient monitoring during the exercise. During the exercise period, you have to monitor the 12 lead ECG at least during last minute of each stage, and blood pressure monitoring. And you have to ask the symptoms of the patient. During the recovery, you have to monitor for at least 6 minutes in sitting or supine position, and you have to take 12 lead ECG every minute, and heart rate and BP blood pressure measurement immediately after exercise and every 2 minutes thereafter. And indications for terminating exercise. This is the most important slide of the talk. So when do you terminate exercise test? So these are the absolute indications when you have to stop. So the ST elevation, if there is any ST elevation without in a leads without Q wave, that is prior non Q waves ST elevations, and drop in systolic blood pressure of 10 mm more than 10 mm mercury, moderate to severe angina, CNS symptoms like ataxia, giddiness, signs of poor perfusion like cyanosis, pallor, and sustained ventricular tachycardia or other arrhythmias that interfere with cardiac output, that is hemodynamically unstable arrhythmias, and technical ECGs. And if patient request to stop, you have to stop. And relative indications are marked ST replacement or drop in BP, increasing chest pain, fatigue, arrhythmias, other than VT, and exaggerated hypertensive response like 250 by 115, and development of bundle branch block. So what should you analyze after a TMT? You have to analyze the clinical response or symptoms, exercise capacity of the patient, heart rate response, blood pressure response, and the ECG changes. So clinical response, symptoms assessment, any chest pain during the procedure, you have to be noted in the conclusion report, and whether the chest pain is similar to the reported chest pain or not. You have to assess the chest pain during the TMT and the history of the patient's chest pain. And exercise-induced angina is the most important clinical predictor of the presence of CAD. And sometimes, even if if there are no significant ST depressions and there is a classic angina during the TMT, it may be taken as a more clinical predictor than the ST segment depressions. And consideration of limiting versus non-limiting chest pain have been incorporated in Duke Threadmill score. We'll see it later. So exercise capacity is a strong mortality predictor and non-fatal cardiovascular outcomes in both man and woman, and it is the best marker for the prognosis. And estimation of predicted meds have formulas for men. This 18 into 18 of 18 minus 0.5 into 0.15 into age, and for women it is 14.7 minus 0.13 into age. And functional capacity. This is a functional capacity for a poor, fair, and average good high performance high performance athletes like. And hemodynamic response, we have to check for heart rate, BP, and heart rate and BP. So we'll check first maximal heart rate. That is most familiar equation is 220 minus age for a middle-aged man, but these are the age predicted maximal heart rate formulas. For men, it is 208 minus 0.7 into age. For women, it is 206 minus 0.88 into age. And if a patient who's on chronic beta blocker therapy for any cardiac disease, then the heart rate formula will be 164 minus 0.7 into the age. And a submaximal study is a study when the peak heart rate is achieved below the APHMR, and as the study will be inadequate if there is failure to achieve 85% of APHMR. At this point, in the case of an inadequate study, you cannot report a TMT as a positive or a negative. And if a patient without known has an inadequate study, it is non-diagnostic. And chronotropic incompetence is inability of a heart to increase its rate according to the demand, and it is defined by this formula. And it is an independent predictor of a cardiac all-cause mortality. And failure to achieve a chronotropic index higher than 80% defines chronotropic incompetence. And for a patient who is on chronic beta blocker therapy, less than 62 is considered as chronotropic incompetence. Heart rate recovery is one more important thing that we have to assess. So it has been defined as less than 12 beats after a post-exercise cool down, or less than 18 beats per minute after 1 minute of cessation, and less than 42 beats per minute after the 2 minutes of exercise. And abnormal heart rate response is associated with increased all-cause mortality. BP normally during exercise, systolic pulse pressure and heart rate pressure, that is double product, everything will increase according to the workload. And diastolic BP increases only minimally, or it may remains constant. And most subjects systolic BP will be more than 140. And exaggerated response of more than 120/90 is greater is called as exaggerated systolic pressure response, but it is not a general indication to stop TMT for this reason. And exercise induced hypotension is defined as systolic pressure drop during exercise below the resting BP or 20 mmHg after the initial increase. So either of these definitions would be absolute reason to stop the test. What are the ECG findings that will happen in the normal subjects? So P wave magnitude increases, PR segment shortens, and QRS duration generally decreases, and J point depression will be seen at maximum exercise, and upsloping ST depressions might be seen in 10 to 20% of normal subjects, and the magnitude of ST depression should be measured at 60 milliseconds after a J point in if heart rate is more than 30 and 80 milliseconds after if less than 130. And T wave, there will be a decrease in amplitude, and U wave, no significant changes, and QT interval decreases. And in some, most commonly in women, it may paradoxically increase the QT segments. And abnormal response, ST segment changes are classically called diagnostic for positive TMT, but sensitivity will be 60 to 70% and specificity will be 70 to 80%. So the traditional manifestation of ST segment depression is horizontal or a downsloping ST depressions, and a slow upsloping pattern also may suggest an ischemic response. The slow upsloping pattern criteria is the depression of 0.15 millivolt or greater and an ST segment slope greater than 1 millivolt per second. So these are the different types of ST changes you see during your during your TMT exercise. This is the normal response. This is a rapid upsloping where you have a very very straightforward ST elevation. Here minor ST depressions. This is a slow upsloping. This is a slow upsloping, and this is horizontal. The right top is a horizontal. Horizontal ST depressions.
Which
And
is the worst among these? Anybody? Where should you stop when you see one of these? Which one? Horizontal, downsloping, elevation. Which one among the three? The non-Q waves. Always remember that. Sorry, get one. In non-Q waves.
non-Q wave elevation is the most important.
Yeah.
Elevation in a Q wave is indicative of RWMA and a dyskinetic or a aneurysmal segment of a particular territory.
That is not ischemic.
The non it is not considered as an ischemic response if a ST elevation is there in Q wave leads. And lead AVR, emerging literature suggests that ST elevation of 1 mm or greater in AVR lead is a significant predictor of left main or a proxial AD or a multivessel CAD. And it is an isolated marker of with good sensitivity and specificity. And these are the features of a high risk TMT. Whenever you have a TMT positivity with less than 5 minutes or a heart rate recovery less than 12 per minute, or ST segment depressions more than 2 mm, ST depressions more than 1 mm within 5 minutes, and ST elevations more than 2 mm, and DTS score more than -11, and exercise induced hypotension or tachyarrhythmias. These are all the features of a high risk TMT test. The prognostic variable, strongest prognosis is exercise capacity, and weakest predictor is ST segment depression. And this is the treadmill test score. This is Duke treadmill score, where you have an exercise duration in minutes, -5 into ST deviation, either elevation or the depression, and -4 of angina index. And if the score is more than 5, it is low predictor, low risk group. If it is less than or more than or -11, it is high risk.
Is there any other score? Anyone knows any other score? There's something called as a Lower nomogram 1. There's a Mayo Clinic score. There's a Cleveland score. It's called as the FIT score, FIT score. You could be asked this, but then as he goes next, yeah. So this is actually a gender specific score.
So this is a gender specific score. We have a heart rate response and ST depressions, age, and angina history, and rest rest other criteria. Basing on this, we'll calculate total score for male and female separately. So next is exercise induced arrhythmias. It is important to recognize during exercise you have multiple arrhythmias, but not all arrhythmias are induced by ischemia, or not all arrhythmias are having a bad prognosis. And multiple arrhythmias you can see are atrial premature beats, AF or atrial tachycardia, VPCs, LBBB, RBBB, excess-induced VT, and heart block. So premature beats, you have almost 10% incidence and is most common excess-induced supraventricular tachyarrhythmia, and excess-induced AF was other type of atrial arrhythmia that you regularly, you can see frequently, and the cause for the excess-induced AF is atrial fibrosis or atrial dilatation, and a modulator is parasympathetic enhancement, and trigger is atrial premature beats. And elite athletes elite athletes are at a higher risk for developing excess-induced atrial fibrillation. And VPCs during exercise testing, 7 or more VPCs is seen in almost 10% of patients without any history of cardiac disease. They may or may not be related to your ischemic heart disease. Exercise-induced LBBP, 0.5% of patients undergoing exercise testing TMT developed transient LBBP that was documented only during TMT without LBBP at rest. And uh, it correlates exercise-induced LVBP with higher heart rates, have normal coronaries, but lower heart rate of less than 120 correlates with occlusive CAD. Exercise-induced RBBP have incidence of 0.24, and multiple studies showed that incidence of CAD is almost 100% in EI-RBBP. And exercise-induced VT is the most coronary artery disease is the most common cause of exercise-induced VT. Apparently, 1% will develop, and exercise-induced VT with a normal structurally heart, you have CPVT, long QT syndrome, ARVC, and Brugada syndrome. And some patients will develop complete heart block transiently during TMT. It is highly specific for your high-grade AV block, and maybe prophylactic pacing may be indicated for these patients. So we'll go to the examples. This is a patient with a initial TMT ECG, and this is the peak excess ECG. And if you can calculate a DTS score, any one of you can calculate the DTS score for this TMT. The ST depressions are almost 3 mm. And this is the duration of exercise, and this is the anginal index. So the DTS will go like 8 minus 5 into 3 minus 4 into 1. So it will come around minus 11. And this patient underwent an angiogram which showed proxillary bifurcation lesion and a RCA mid 90% stenosis, for which he underwent a RCA plasty. And this is one more female. She had a resting ECG T inversions, but it was chronic T inversions. So she underwent a TMT here, and she developed exercise-induced LBBP. This is the TMT during peak exercise, and she underwent an angiogram which showed proxillary 80% stenosis, and she underwent a LAD plasty. So this is one more patient who was a young male with a atypical chest pain. So he underwent a TMT, and during TMT he had a multiple VPCs, runs of VPCs, but overall the test was negative, hence he was not performed coronary angiography. So this is brief about TMT, and you can